The topic of discussion today is meningococcal vaccine, is it time to give it as in routine childhood vaccination in private practice in India? We all know that it is not part of the national childhood immunization program, but pediatricians do have the doubt whether it is time to administer these vaccine in one-to-one practice, especially since two important these vaccines are available in the market. To arrive at a decision, at a conclusion regarding this, we will go step by step. We will have to know the prevalence and severity of the disease, that's meningococcal disease, to know we need vaccination routinely. We will have to know what is the vaccines that are available in the market, especially in India, where therefore those will be the vaccine of interest. We will not be talking about vaccines which are available in the international market, but not in the local market much. And definitely we will base our opinions on the what the international national bodies advise regarding this. Especially we will take into consideration definitely the WHO and IAP, and of course CDC also. And we would look at the international practices. What other countries are routinely giving meningococcal vaccine, in which countries are not. And from this, we will come into an evidence-based conclusion of whether these meningococcal vaccines should be given in private practice in India. Now, some of the basic information which you as pediatricians were more likely to know, or you should be knowing, I will run through because this has a bearing on the decision we make regarding giving meningococcal vaccine routinely. It's an unpredictable disease which can be easily misdiagnosed at an early stage with non-specific symptoms such as flu-like symptoms. If you are a honest pediatrician practicing for a long time, you will admit that you did delay the diagnosis once in a while, meningococcal disease especially. Meningococcal disease is associated with rapid onset of epidemics, significant risk of death with a high fatality rate up to 50% in untreated cases, and high frequency, 10 to 20% of severe sequelae from brain damage, hearing loss, and other such long-term disability. The bacteria in meningococcus only infects humans. This is a very important point, and are transmitted from one person to another through droplet respiratory or throat secretions via carriers through close contacts. Now, because it affects only human beings, once you eradicate, you control it in humans, there is a chance of eradicating the disease. There's no animal reservoir. Now, meningococcal disease is categorized into 12 distinct serogroups, of which only 6 are of major importance. They are A, B, C, polysaccharide, based on the polysaccharide, capsular polysaccharides. W, X, Y. W135 is what is the usual strain in W, and are known to cause majority of the invasive meningococcal disease globally. Highest incidence in infants and young children. This is important because the decision to give vaccination, this becomes very important. Highest incidence in infants and young children, as well as older adults, where case fatality rate are high and often due to underlying comorbidities. This is a disease, unlike pneumococci and H influenza, is a problem both in adults also, that also you should realize, and causes high mortality in adults. Many but not all countries have a small peak of invasive meningococcal disease in a late adolescence and adulthood, especially when they go to boarding schools or they go to army, etc. There is a chance of an epidemic at that time. In the African belt, now we come to the definition of what an epidemic is. In the African belt, the meningitis, the WHO definition of an epidemic is more than 100 cases per 100,000 population per year. In endemic countries, the incidence of more than 10 cases, 2 to 10, and less than 2 cases per 100,000 per year are characterized as high, moderate, and low endemicity, respectively. This is an important point. Wherever you have more than 10 cases per 100,000, you call highly endemic, 2 to 10 moderate, and below 2 cases per 100,000, it is characterized as mild. It is not based on the total number of cases. The importance of that I will come to you later. An outbreak outside the meningitic belt may be defined as a substantial increase in invasive meningococcal disease in a defined population, about that which is expected by place and time. Therefore, in African belt, if you say more than 100 cases per 100,000, that need not be what will happen in a southern state of India, where normally only about 3 or 4 cases may occur in a year in a particular place. Therefore, it depends on the normal cases which happen in that particular area in that particular point of time. Now this map gives you a distribution of the strains, the 6 strains which are the most important and of interest to us. Few points you have to understand. In Europe, dominant is the B and the C strains. Now the C strains have become less because the monovalent vaccine was introduced, if I am not mistaken, by 2009, and therefore that has been more or less controlled. But still you will find. Therefore the whole of Europe you find now meningococcal B being a major problem. The other major issue is about the sub-Saharan belt, which extends from Ethiopia to Senegal, where you find the major epidemics occurring with A, and other strains like C, W135 and X have all become important. X has become important here also. All this has a bearing when we discuss the vaccination. America has a distribution of B, C and Y. Of course, you know, these are dominant strains. Every strain can be present there. And and Australia has again B strain, because many of them have controlled the C, meningococcal C, with vaccination, and that was the first vaccine which came into the market. Now our interest is in India. In India, the epidemics has been caused by A strain. Endemics, all other strains are present. And in India, one important point is South India, which has a more tropical climate, has less incidents, less epidemics than the North India. And another point to note is in Middle Eastern countries, especially Saudi Arabia, all the strains are present, but W135 is prevalent in a very high way. And this, when they go to Hajj, it's very important that they take vaccines containing W135. These are some important points regarding strains distribution across the world. To reinforce what we have already said, these pyramids are major epidemics in general population. And there's a map of India, which you see the most of the pyramids are in North India. The major epidemics described in India are New Delhi in 2005 and 2008 and 9 in Meghalaya and Tripura. If you look at South India, there are small pyramids, but their height is low. That means they are not major epidemics. And it also reinforces the view that the more temperate climate, you find more epidemics. Now, India is described as a country with low endemicity, but prone for epidemics. But the epidemics that occur in India are nowhere near what happens in sub-Saharan Africa, where about 30,000 to 40,000 cases occur when they do occur, and they occur every 5 years. In India, it occurs once in 10 years or something, and the cases are limited to about 10,000. Some facts about meningococcal disease in India is that meningococcal disease is a notifiable disease in India, even though reporting is not mandatory. It's a rather complicated situation. Therefore, many cases are probably not reported. Data on the burden of endemic disease remains unreliable, because this is a major point when we discuss whether we should give meningococcal vaccine routinely or not. Data on the burden of endemic disease remains unreliable because of limited disease surveillance, insufficient laboratory capacity, misdiagnosis, and extensive antibiotic use, which is prevalent in India. Therefore, most of the antibiotics, if at all a CSF is done or a blood culture is done, most of the patients have already received antibiotics before this. Therefore, this leads to severe underreporting. It is therefore likely that the real epidemiology and burden of disease could be underestimated. This will have a terrible bearing on the decision we take whether to vaccinate or not vaccinate. Now, the Integrated Disease Surveillance Program does conduct routine disease surveillance, but this information is not part of the public domain. Again, this is very surprising to me. Then for what are they doing it? Thus, the actual data on disease surveillance remains unknown. At the same time, the available data is from the National Health Statistics, presents a high rate of meningococcal disease incidence, which cannot be confirmed independently. In the National Health Profile published in 2019, which showed about 2017, what happened in actually it is the data of 2017, you will find that some of the cases, states did have a high incidence of cases. This column gives you the total cases, 552 total cases in Andhra, Bihar 375, death in Andhra was 67. That's not very small. Karnataka had 276 with one death, and my state Kerala 9 had death, one death. Uttar Pradesh has 118 and West Bengal 901. And West Bengal at that time had an epidemic with 116 deaths. Therefore, these are not something which you can ignore. And if you look at the total cases in India, in 2017, it was 3498 and the deaths was 229. Now, this is what will be highlighted in the, if you have a drug company which has an interest in promoting their vaccine, would highlight this statistics very much. And these are true from the National Health Profile. Looks very high. But in India, either the World Health Organization, WHO, classifies meningococci on the basis of total number of cases plus 100,000 population. Therefore, this comes only in low, that is less than 2 per 100,000 population. And if you look at it in 2018, it's slightly less, 3,382 with 152 deaths. Here again, Andhra Pradesh was having 758 with 45 deaths. If you look at up in Karnataka, 153 with 0 deaths. And Kerala had 5 cases with 1 death again. And Uttar Pradesh 283 and 8. Therefore, there are, and West Bengal again 987 and 80. Therefore, if you look at the statistics of 2017 and 18, there are a considerable amount of death, but by the classification of the WHO, it will still not come as, only come as, the endemicity will only come as mild, not even moderate. In 2018, published the hospital-based sentinel surveillance bacterial meningitis study. As the other studies, the meningococcal meningitis came third for the reason for bacterial meningitis below streptococcal pneumonia and H influenza. Now in Alleppey Medical College, it accounted for 16.7% of invasive of bacterial meningitis. And in Trivandrum Government Medical College, it accounted for 8.7%. While the total of all the medical colleges which were studied, Bhubaneswar, Chennai, Madurai, the total was only 2.7%, slightly higher in Kerala, probably because the hip vaccine was more given to the children here. Next, we will come into the meningococcal vaccine of interest. The main meningococcal vaccine of interest for us are the quadrivalent meningococcal conjugate vaccines. Now, there are polysaccharide vaccines as well as conjugate vaccines which are conjugated to protein for beta antigenicity. We will not be discussing polysaccharide vaccine because that is not, that's not recommended by the IAP also. Now, the two vaccines which are of special interest to us is Minactra and Menevo, which are we will be discussing in the next slides, and because they are the vaccines which are available in India today. And the other vaccine internationally of interest is meningococcal B vaccine. Meningococcal B vaccine is important in Europe, America, because this strain is more prevalent there. And there is a problem with this vaccine, meningococcal B, because it's poorly antigenic, because it cross reacts with human antigens and human neuronal antigens. But even now they have brought about 2 vaccines which contains meningococcal B, and it is known to produce reasonably good immunity, but now they don't seem to produce herd immunity. The other vaccines which we should know, which are not of direct importance as far as private vaccinations in India is concerned, is the monovalent vaccine against serogroup A. And this is manufactured by Serum Institute of India, but surprisingly, they don't seem to market it in India in a big way. Available in Africa, and is given in a huge in the sub-Saharan belt. This is the vaccine which is administered for controlling the epidemics of meningococcal A. And we have monovalent vaccine C, which was given in the Western world 2009, eliminated almost meningococcal C. And there is a combination with Haemophilus influenza and meningococcal C also available in the Western world. Not much of interest to us. Now, one more vaccine of interest which the postgraduate students should know is NMCV5, which is a vaccine which is effective against 5 serogroups. Again, manufactured by the Serum Institute. Over its effectiveness of A, C, W, and Y, it is effective also against the X strain. This is a new vaccine, therefore this can be a topic of discussion for postgraduate students. And now this is also manufactured by the Serum Institute. If you have the habit of reading Lancet Infectious Disease, etc., they are very excited about this because they say with these two vaccines, meningococcal A, monovalent meningococcal vaccine, as well as NMC vaccine, which contains X strain also, they are planning to eradicate, note my words, eradicate meningococcal in Africa. Surprisingly, marketed by Serum Institute of India, this doesn't seem to be available in India. But even this is now a vaccine which is just on the research table actually, but will be soon applied in African belt. With this, to go into some of the details of the quadrivalent vaccines which are available in India, the quadrivalent meningococcal conjugate vaccine using diphtheria toxin as the carrier protein, that is Minactra, which is marketed by Sanofi company, is licensed for children 2 to 55 years in a single dose, in one dose. And in a 2-dose series of this vaccine is licensed for children 9 to 23 months. Therefore, below 2 years and above 9 to 23, you have to give 2 doses, and above 2 years is a single dose, that is Minactra. Now the other vaccine, Menova, which is marketed by Glaxo, which carries CRM as the protein, as the carrier protein, which is nothing but a mutant strain of the diphtheria toxin, and it is licensed only about 2 years, and is a license as a single dose. Now, regarding this meningococcal vaccine, you should understand, due to relative low incidence of meningococcal disease, pre-licensure clinical efficacy studies are not feasible. Meningococcal polysaccharide vaccine and protein conjugate vaccines are licensed based on the evidence of the immune response. Because the disease prevalence is so low, you cannot do a field study in this. Efficacy studies are not possible. Therefore, they're based on evidence of immune response in vaccinated subjects using serum bactericidal activity as the immunological correlate of protection. But in experience, the maximum experience we have is meningococcal C vaccine. And we have found that 10 years of experience in countries with adequate surveillance systems have shown large reduction of meningococcal C disease as a result of meningococcal C conjugate vaccine. Therefore, now that we have based the effectiveness on immune serology, we have found the effectiveness on the ground for meningococcal C vaccine. Herd protection is seen in most countries. This is a little disputable. In some studies, they say there's no herd protection. In others, they say there is herd protection, which is very important when you have a killer disease like meningococcal disease. Now, because there are two company with two vaccines, doctors are bound to be bombarded with one company of the advantages of the other. Actually, both vaccines are good immunogenicity and are well tolerated. The side effects are very few, serious side effect fatality almost unheard of. But then look from where I am quoting this meningococcal diseases WHO position paper November 2011, they make a loaded statement here. The response to CRM quadrivalent vaccine, which is the Meningococcal vaccine by Glaxo, was statistically non-inferior to Minactra A, C, W, and Y for all groups, and statistically superior for group C, W135 and Y. Therefore, they seem to be suggesting in certain things they are equivalent, and certain they are even better. That is, Menova is slightly better in antibody response to Minactra. But this is this is there in the WHO position. Now, to stress the advantage of this safe vaccine, none of the vaccine has been, is meningococcal vaccine has been associated with any serious side effect either during clinical trials or post-marketing surveillance. Therefore, these vaccines, both quadrivalent vaccine, are quite safe and effective. Redness, swelling, and pain in the site of injection may occur. Such reaction usually start within the first day of immunization and last 1 to 3 days. Less commonly, the children may develop fever or irritability for a short period of time. Minactra Minova can be administered at the same visit as other indicated vaccine with one exception. Interference with PCV13 immune response was noted when Minactra and PCV13 were administered simultaneously in patients with asplenia only. Remember, note this, Minactra with asplenia, there was an interference. Hence, CDC and ACIP now recommend that at least 1 month interval should be kept between PCV13 and Minactra, and PCV13 should be administered first. And now next, what you are concerned about, the cost effectiveness. 6 countries undertook an evaluation of the cost effectiveness of meningococcal vaccine, and all concluded that 1 dose in the 2nd year of life was more cost effective than a 3-dose infant. When considering private immunization, the cost effectiveness is not something which gives the top priority. A dynamic transmission model suggests that the most cost-effective strategy was routine vaccination of children at 12 months of age, combined with a catch-up of all children and adolescents less than 18 years of age. And taking herd immunity into account, this improved the cost-effectiveness of the vaccine very much. After having spent some time in the vaccines of interest, mainly the quadrivalent meningococcal conjugate vaccine, now let's look at the turn towards the WHO recommendations to find a way whether these vaccines should be given routinely in a practice or not. Now, the WHO countries, according to WHO, countries with a high or moderate endemic rates, high is more than 10 cases per 100,000, and moderate cases are 2 to 10 cases per 100,000 of meningococcal disease, and countries with frequent outbreaks should introduce large-scale meningococcal vaccination programs. The vaccine may be administered through national immunization program, while supplementary immunization activities may be conducted during epidemics. By this criteria, India does not qualify for that. In countries where the disease occurs less frequently, less than 2 cases per 100,000, the WHO recommends meningococcal vaccination for high-risk group only, such as children and young adults residing in close communities, example boarding schools or military camps. Therefore, routinely, India does not qualify. Definitely, South India does not qualify because it doesn't have epidemics. It doesn't have. It has a prevalence less than 2 per 100,000. Now, laboratory workers at risk of exposure to meningococcal and travelers to high endemic areas, and all children suffering from immunodeficiency, asplenia, terminal complement deficiency, and advanced HIV infection should be vaccinated. If we move from WHO to IAP, and in the guidebook of 2018 and 19, they are very categorical. The current epidemiology and burden of meningococcal disease in India do not justify the routine use of meningococcal vaccine. They are a little categorical, and I'm a little surprised in this because in private immunization, they say they take a different attitude, but looks a little surprising to me. I'll come into that later. And they say meningococcal vaccine are recommended for certain high-risk conditions and situations. Already we have enumerated about 2 years. 3 months or older if the risk of meningococcal disease is high, example outbreak, close household contact. Therefore, if there is an outbreak or an epidemic, only above 3 months you can give. Below 3 months, probably only prophylaxis can be done. And they do not advise this routine vaccination. Now, I don't want to go into special category in which they have advised what and all, because that's not the point of discussion of us today. Just to make a passing mention, when there is an epidemic, the vaccine which they advise is monovalent meningococcal A vaccine. But there's nothing wrong in giving the quadrivalent vaccine also. Now, if you want to know what they have given in 2020-21 advisory committee vaccine immunization schedule, if you look at it in the meningococci, they have put it in blue, and they advise dose in 9 months and 12 months. That means vaccine in special situations, not routine vaccine, special situation only, which we have already mentioned. And what can be given at 9 months and 12 months? Minactra is approved as a 2-dose schedule between 9 and 23 months. Minimum interval between the doses should be 3 months. Menveo is recommended as a single dose about 2 years of age. Therefore, this is the recommendation of the Indian Academy of Pediatrics 2020-21, the latest. We have to know that. And it was only in this 2021 they approved Menveo for children. At this point, it would be worthwhile looking at some of the international immunization practices. In fact, among all the countries, 190 countries or so only about 30 countries routinely give meningococcal vaccine in their childhood immunization. And one of the countries which take lead in this matter is UK. From 2009, if I am not mistaken, meningococcal C vaccine is given at 1 year of age. And they give the second dose as a quadrivalent vaccine at 14 years. Now, meningococcal B from 2015, that was the first country to give meningococcal B routinely in childhood immunization 2015. They gave at 8 weeks, 16 weeks, and at 1 year. As I have already pointed out, meningococcal vaccine, B is a major problem in Europe, especially in UK, and the vaccine is not that immunogenic. But this was a new entrance into that. Now, if you look at United States of America, it's slightly different. They prefer to give quadrivalent vaccine from the beginning, but they don't give it in childhood. They give 2 doses, one at 11 to 12 years and the other 16 years of age. And if they miss it at 16 to 12 years, they give it 13 to 15 and 1 dose, and a booster 16, 18 with a minimum of 8 weeks between these 2 doses. And older people, they have a discussion with the adolescents or young adults above 16 and decide and make a informed decision. Therefore, if you look at the vaccination strategy of internationally, only about 30 countries are giving the vaccine. America from the beginning is giving quadrivalent vaccine. Now Canada is also following suit. Most of the Europe was giving only meningococcal C vaccine. Some of them have started giving meningococcal B vaccine also. With all this evidence behind us, it's time to make an evidence-based decision now. The question before us was at the beginning, is it time to administer meningococcal vaccine routinely in private immunization? Now, the green is what is for and red will be what is against it. Now, well, let's see what are the evidences for it. It's a disease which has a high mortality and difficult to diagnose early enough. Therefore, that is a point in favor of giving immunization for children. And there is an availability of effective and safe vaccine. Though it might be a costly vaccine, in private practice, cost doesn't matter, as the parents would always like to do the best for their children. Therefore, there is an effective and safe vaccine. In fact, meningococcal vaccine, hardly any mortality has been described after vaccination, unlike many other vaccines like COVID, etc. And prevalence underreported because of limited diagnostic facilities, empiric antibiotic treatment use, etc. Now the prevalence has been said to be low, but it is underreported because of these factors and many other factors. For all these points towards giving routinely meningococcal vaccine. Now, what's the point against? Now, as per WHO recommendation, South India does not qualify for giving immunization routinely. This is because the prevalence is less than 2 per 100,000, and even North India, taking India per whole, the prevalence rate, India is regarded as a country with low endemicity, but there is a prone for epidemics. But epidemics occur only once in 10 to 15 years, actually 20 years, and they tend to be less severe than in African belt. Therefore, as per WHO recommendation, it does not come. Now, let me tell you that the companies might be telling that the total number of cases are high. It is about 4,000, with deaths also tend to be in hundreds. But that is not considered by WHO as a for recommending the vaccine, because per 100,000, it is on the low endemicity side. Normally, IAP says they recommend what is best for the patient, for individual patients. Therefore, even then, the IAP does not recommend meningococcal vaccine in spite of all these points. They have not discussed this in detail, but they clearly mention that it is not time to give routine immunization. And that's the position they have taken even in 2021. Now, but if you look at the situation, I mean, I'm just a passing mention, I would say, if you look at the epidemics in India, it occurred in 1930 after a period of maybe in 1960 there was a small epidemic. Definitely in recent years, 1980 there was a major one in Delhi. 2000 there was in Meghalaya and Tripura. Therefore, 2021 we are in for another, after 20 years, this time for another epidemic, especially in North America, North India. Now coming to the final verdict regarding whether we have to give immunization routinely or not, this is a gray area. If this is not a gray area, I wouldn't be discussing this topic, and I would not be putting a video on this single question, important question. The answer I would say is routine immunization for meningococcal vaccine will have to be no, because especially when the WHO finds that India has a low prevalence of meningococcal vaccine, and the IAP, which normally in one-to-one immunization takes a more favorable stand, is definite that we should not be giving at this point of time. Therefore, routinely it cannot be, though there are scientific points in favor of giving it. Counseling, definitely yes. Why? Because you have a vaccine which is safe, which is effective, and the disease is a killer disease which kills in hundreds all over India, and it affects children with debilitating after effects in thousands all over India. And therefore, no parent, if you have been regularly vaccinating, looking after a child, vaccinating, and if the patient develops meningococcal for some reason, he is never going to pardon you, and he'll justifiably be angry with you. He has all the rights to even sue you, I would say. Therefore, you have to place everything in front of him, the full information. And if they choose to take the vaccine, the best option would be 9 and 12 months Minactra, and probably a booster 16 years when he is more prone as an adolescent, when he goes to boarding, etc. 9 and 12 months, because it's in infancy, the disease is more common. And if some parents would not like to give too many injections because already the children have become a pincushion with multiple immunization, then you can offer them at 24 months and a booster at 16 years, in which case Minavo can be the choice. And finally, some older children come to you for immunization advice when they are going to boarding or school, and some of the jobs also, they entail them to take a vaccination. Normally, I advise them viral hepatitis, typhoid, chickenpox, and also a meningococcal vaccine. These are offered to them, especially if they are going to boarding. And if they are going abroad, you will have to tell them that this quadrivalent vaccine, especially to Europe or UK in particular, you have to warn them that the meningococcal B vaccine is not available in India, not been given, and the quadrivalent vaccine which you are administering will not protect them against it. Thank you for investing your time watching my video. If you are interested in communicating with me, you can email me on this particular email address. My other videos can be found in YouTube in this particular net address, as well as I also blog on this wordprocess.com. Thank you once again.